welcome to this lecture on the trigeminal nerve. I am Tanya Chamberlain from the Division of Anatomy here at the University of Leeds, and in this video we will be looking at the innervations of the oral cavity. After this video you should be able to complete these learning objectives. Pause the screen if you need to, but you can find them in your complementary learning objective package. So why are we so interested in the trigeminal nerve? Well, the trigeminal nerve is particularly important in the field of dentistry, especially branches V2 and V3, which will go on to innervate the teeth. The trigeminal nerve is a complex nerve that gives rise to many branches, in particular sensory branches which are travelling to the face. But it also gives a motor branch which is going on to innervate the muscles of mastication. It can have huge clinical significant implications, such as in cases of shingles or trigeminal neuralgia. The top image here demonstrates the distribution of shingles along the ophthalmic nerve. Shingles is a very painful condition in which dormant varicella zoster virus reactivates along the length of the nerve. It can have significant consequences if the nerves of the face are affected. The bottom image represents the close proximity of an artery, identified as an arterial loop. This rubs on the trigeminal nerve and causes trigeminal neuralgia. This is an extremely painful condition which can be severely detrimental to a patient's quality of life and is sadly referred to as the suicide disease, given the high prevalence of suicide in the patient population known to have this condition. The final reason why it is important to have a thorough knowledge of the trigeminal nerve in dental careers is to ensure you can adequately provide dental anaesthetics for your patients. Pain-free applications of anaesthetics are vital for the comfort of your patients during dental work, so having an in-depth understanding of the trigeminal nerve will help to ensure your patient's requirements are met. Firstly, let's have a look at the origin of the trigeminal nerve and the location of the ganglion in reference to the skull foramina. The right image is a sketch of the undersurface of the brain, and the left image represents a blown-up version of the region of the brain we shall focus on, called the brainstem. This more primitive region of the brain that is concerned with transmitting the information between the body and the higher centres, with a whole raft of regulatory and reflex actions, many of which, such as breathing, are of vital importance to life. 10 of the 12 cranial nerves emerge from it. The brainstem is made up of distinct regions. The trigeminal region emerges from a region called the pons. This is the Latin name for bridge. In this picture you can see the main sensory route of the trigeminal nerve. These are parts of the nerve running from the brainstem to the respective trigeminal ganglion. We have one trigeminal nerve for the left side of the face and one for the right. They are quite short, around 1 centimetre or so. Right next to the sensory route we can see a much smaller route. This is the motor route. The motor route travels along the sensory route and the ganglion before leaving the cranial cavity with the mandibular nerve. It fuses with V3 just after they both leave the skull. As a result, there are no motor fibres in the ophthalmic or the maxillary nerves, and none in the trigeminal ganglion. The trigeminal motor fibres are only found in its motor route and the mandibular nerve beyond the point that the motor route joins it. The trigeminal ganglion is a sensory ganglion, and it is formed from the sensory root. It contains the cell bodies of those neurons, which convey the sensation of pain, touch, proprioception of the TMJ and teeth, and pressure from the skin and oral mucosa, tension of those tendons of the muscles of mastication. The motor root of the trigeminal nerve joins the fibres from the sensory trigeminal immediately after the formation of the ganglion. The ganglion divides into its 3 main branches of the trigeminal nerve to form an ophthalmic nerve, also known as V1, the maxillary nerve, also known as V2, and the mandibular nerve, also known as V3. Let's take a look at how these 3 divisions of the trigeminal nerve get out of the cranial cavity. In the middle and left-hand pictures we are looking down into the cranial cavity with the brain removed. You can clearly see 3 distinct regions of the cranial base called the anterior, middle and posterior cranial fossa. A fossa is a depression or hollowed out region, usually in a bone. You can see the trigeminal nerve on the left-hand picture. Note how it passes from the posterior cranial fossa to the middle one by running over the petrous or rock hard part of the temporal bone. Once in the middle cranial fossa, the sensory root quickly expands to form the trigeminal ganglion. This is where all of the cell bodies of the trigeminal sensory fibres are located. This is where there is a swelling or ganglion at the nerve at this point. 3 divisions of the trigeminal nerve sprout from the ganglion and leave the cranial cavity through 3 different openings in the skull. All of these openings are in the sphenoid bone. The ophthalmic nerve travels anteriorly to pass through the orbit through a slit called the superior orbital fissure. If we take a look at the orbit from an anterior perspective, we can see the superior orbital fissure here. The maxillary nerve also travels forward, but instead of passing through the orbital fissure, it goes through an opening called the foramen rotundum. This is most clearly seen in the right, which shows the cranial base with all the soft tissues removed. The mandibular nerve travels most directly downwards to pass out through the skull through an oval-shaped foramen called the foramen ovale. The motor root of the trigeminal nerve travels through foramen ovale as well. Again, this foramen is best seen in the right image. The image on the left demonstrates a dissection of the ophthalmic nerve, whilst the image on the right is a sketch that will help you to understand the cadaveric anatomy. Here we can see the ophthalmic nerve shaded in pink. The ophthalmic nerve, or V1, exits through the superior orbital fissure and begins to divide into smaller branches immediately upon entering the orbit. Reverting back to the superior orbital fissure, we can see it here from an anterior perspective and witness the division of V1. Within the orbit, the supraorbital nerve, a branch of V1, traverses above the eye and travels superiorly through a groove called the supraorbital notch to supply the sensory innervation of the forehead. V1 also gives off lateral nasal nerve, which travels medially to the eye and will provide sensory innervation to the lateral aspects of the nose. The final branch of V1 contributes to something called the ciliary ganglion, located behind the eye. The nasociliary nerve that contributes to the ciliary ganglion provides sensory innervation to the cornea, ciliary body, and iris of the eye. That's all we need to know about the ophthalmic nerve for dentistry, so we should look at the bread and butter for this video. V2 enters the cranium via foramen rotundum and travels into a space between the viscerocranium and the neurocranium called the pterygopalatine fossa. We have 2 pterygopalatine fossae, one located on the left and one located on the right. The pterygopalatine fossa sits behind the maxilla. The medial boundary of each fossa is the perpendicular plate of the palatine bone, whilst the lateral boundary is marked by a space called the pterygopalatine fissure. This is a space which we would look into the fossa. Behind the fossa, we have the pterygoid process and the greater wing of the sphenoid. The pterygopalatine fossa is important, particularly in dental anatomy, because it contains some very significant structures. Within this space, we have the termination of the maxillary artery, the emissary veins, the maxillary nerve, as discussed, and something called the pterygopalatine ganglion, which we will come on to in a few moments. An all-important nerve which you will meet a lot in your dental career, the posterior superior alveolar nerve. Some of the maxillary nerve can be seen in this image. I'll shade it in to make it a little bit more obvious. It is important to note that this is far from the extent of the maxillary nerve, as the nerve covers a great proportion of the facial anatomy, both superficial and deep, which cannot be fully appreciated from a single perspective as seen here. Firstly, let's cover some of the more simple nerves that travel from V2. On these sketches, we can see the lateral aspect of the maxilla on the left side of the face. We can see the space which we now know to be the pterygopalatine fossa, shaded in dark. In order to visualise this space, we are looking through the pterygopalatine fissure. V2, or the maxillary nerve, is seen here, directly branching from the trigeminal ganglion and exiting the cranium through foramen rotundum. We can see this branch here, which is the posterior superior alveolar nerve. The posterior superior alveolar nerve originates from the maxillary nerve in the pterygopalatine fossa, and passes laterally out of the fossa through the pterygopalatine fissure to enter the infratemporal fossa. It continues laterally and inferiorly to enter the posterior surface of the maxilla through small alveolar foramen, approximately midway between the last molar tooth and the inferior orbital fissure. It then passes inferiorly just deep to the mucosa of the maxillary sinus to join the superior dental plexus and innervate the maxillary molars and buccal gingiva. The infraorbital nerve is a continuation of V2 that leaves the pterygopalatine fossa through the inferior orbital fissure. It lies first in the infraorbital groove on the floor of the orbit and continues forward in the infraorbital canal. Whilst in the infraorbital canal, the infraorbital nerve divides to form the middle and anterior superior alveolar nerves, which ultimately join the superior alveolar plexus to supply the upper teeth. The middle superior alveolar nerve also supplies the maxillary sinus, is not visible on this sketch. The anterior superior alveolar nerve also gives origin to a small branch which passes medially through the lateral nasal cavity to supply parts of the areas of the nasal floor and walls. Again, this is not visible on this image. The infraorbital nerve exits the infraorbital canal through the infraorbital foramen. Here it divides into nasal branches, supplying the skin over the lateral aspect of the external nose and part of the nasal septum, palpable branches, which supply the skin of the lower eyelid, and superior labial branches supplying the skin over the cheek and upper lip and related oral mucosa. That's a lot. Unfortunately, we aren't finished yet, but I need to clear up this image. The zygomatic nerve originates directly from the maxillary nerve in the pterygopalatine fossa, which it exits to enter the orbit through the inferior orbital fissure. It passes forward onto the lateral orbital wall and divides into the zygomatico-temporal and zygomatico-facial branches. The zygomatical temporal branch continues forward at the base of the lateral orbital wall. It passes through a small bony canal in the zygomatic bone and enters the temporal area to supply the skin over the temple. The zygomatico-facial branch also passes forward at the base of the lateral orbital wall and leads through a small bony canal in the infraorbital margin. It passes through many small holes on the anterolateral zygomatic bone to supply the overlying skin in these regions. Before we look at a more complicated nerves, we need to address the pterygopalatine ganglion. This is the largest of 4 parasympathetic ganglions in the head. The parasympathetic ganglion is found within the pterygopalatine fossa. Now, strictly speaking, the pterygopalatine ganglion does not house any of the trigeminal nerve fibres, but instead the trigeminal nerve passes through this ganglion. However, in doing so, some of those fibres from the parasympathetic ganglion hitch a ride with the peripheral trigeminal branches and will deliver parasympathetic innervation to which the trigeminal nerve is travelling. This will promote mucosal surfaces and glands to secrete. Please remember, it is not the trigeminal nerve which is causing the release of mucosal secretions, but instead fibres from the facial nerve that are synapsing in the pterygopalatine ganglion and travelling along these branches of the trigeminal nerve. The palatine nerve passes inferiorly from the pterygopalatine ganglion. Remember, the sensory component is arising from V2 of the trigeminal nerve, and as these fibres have passed directly from V2 and travelled through the pterygopalatine ganglion. As they pass through, some parasympathetic and sympathetic fibres have travelled with the trigeminal fibres, but they will not have sensory components. The palatine nerve travels within the palatine canal and enters the oral surface of the palate through the lesser and greater palatine foramen. The greater palatine nerve travels anteriorly through the greater palatine foramen to innervate the oral mucosa of the hard palate, whilst the lesser palatine nerve travels posteriorly through the lesser palatine foramen to innervate the oral mucosa of the soft palate. The pharyngeal nerve passes posteriorly from the pterygopalatine ganglion and leaves the fossa through the palatovaginal canal, which then supplies the mucosa and glands of the nasopharynx. The last nerve we'll address on this image is the nasal nerves. The 7 nasal nerves pass medially through the sphenopalatine foramen to enter the nasal cavity. We can't see where these end up on this image, so we're going to have to amend our orientation and depth of dissection to reveal some of them. So this image on the left is the lateral aspect of a patient facing to the left. So we can see where the patient's right eye is and buccal surface of the maxillary molars. What we need to do now is dissect the head just off the midline and open it up like a book to see the lateral nasal wall and the medial wall of the right nasal cavity. So the image on the left is the lateral wall of the right nasal cavity, whilst the image on the right is the medial wall of the right nasal cavity. We saw in the last few slides that the nasal nerves of V2 exit the pterygopalatine fossa through the sphenopalatine foramen, where they enter the nasal cavity. On this open book image, we can see the sphenopalatine foramen. Most pass anteriorly to supply the lateral wall of the nasal cavity, whereas others pass across the roof to supply the medial wall. One of the nerves passing across the roof to supply the medial wall of the nasal cavity is the nasopalatine nerve. This is the largest of the nasal nerves and passes anteriorly down the nasal septum, through the incisive canal and foramen in the hard palate to enter the roof of the oral cavity and supply the mucosa and gingiva and glands adjacent to the incisor teeth. That, you'll be thankful to hear, is the last of the significant branches of the V2. So nerve blocks in the maxillary region aren't supplied as frequently as those in the mandibular teeth. This is because the maxilla is very porous and handles the application of locally infused anaesthetic solutions pretty well. Its porosity allows for the distribution of anaesthetic solutions to the appropriate tissues. However, it is important to know that there are plenty of clinical scenarios in which you might need to perform a maxillary nerve block. So we'll briefly discuss how each of these nerve blocks will affect the oral cavity. Let's recap visually the innervations of the hard palate. Here is an image of the hard palate as viewed from the inside of the mouth. We can see the maxillary molars at the bottom of the image and the maxillary incisors at the top of this image. We are looking at the hard and soft palatal mucosa. Remember that the right and left are switched around in this image because we are looking at the patient's right and left. I'll stick these labels on to prevent confusion. To anaesthetise the palatal gingiva, we have to anaesthetise the greater palatal nerve, or the nasopalatine nerve. If we are working on the palatal gingiva of the molar and premolars, we would only have to apply anaesthetic solution to the greater palatal nerve. This can be administered by washing the greater palatal nerve as it exits through the greater palatal foramen. Note, however, if we anaesthetise one of the greater palatal nerves, only the ipsilateral palatal gingiva will be anaesthetised. Therefore, if we administered anaesthetic solution over the right greater palatal nerve, only the right palatal gingiva would lose sensation. The palatal gingiva on the incisive teeth is a little more complex. The palatal gingiva of the incisors is dually innervated. That means it receives innervation from the greater palatal nerve and the nasopalatine nerve. Therefore, if working on the incisive palatal gingiva, it might be necessary to administer a greater palatal block and also a nasopalatine block, as shown here. A nasopalatine block can be administered by aiming for the nasopalatine nerve as it exits through the incisive foramen of the maxillary bone immediately behind the central incisors on the midline. To anaesthetise the maxillary teeth, we may have to anaesthetise the superior alveolar nerves. Anaesthetising the superior alveolar nerves also has the added benefit of anaesthetising the tooth buccal or labial gingiva. However, it is not as simple as that. We'll start with the simplest teeth, which are M3 and M2, and the distal and palatal root of M1. These three regions are innervated by the posterior superior alveolar nerve. The posterior superior alveolar nerve also innervates the buccal gingiva of the entirety of M1, M2 and M3. However, although the innervation of these regions are the easiest to remember, the application of anaesthetic solution is potentially the one that's going to have the most considerable complications. The posterior superior alveolar nerve is located near the pterygoid venous plexus. If the pterygoid venous plexus is accidentally punctured, this could cause significant hematoma or potential route of infection into the cranium, as the pterygoid venous plexus communicates with the cavernous sinus. This is located in the cranium. Additionally, administering anaesthetic solution into the venous system could also cause systemic effects. The landmarks associated with the posterior superior alveolar nerve are the mucobuccal folds at the level of M2, aiming the needle towards the maxillary tuberosity, which the bony prominence towards the distal end of the maxilla. Moving on, let's have a look at the maxillary premolars and the mesial root of M1. These teeth are innervated by the middle superior alveolar nerve. However, the buccal gingiva of these teeth is dually innervated by the middle superior alveolar nerve and the infraorbital nerve. This picture demonstrates the landmarks of the application of anaesthetic to the MSA. The injection site is at the mucobuccal fold at the level of the apex of the second premolar. The landmarks for the infraorbital nerve block sign are seen here. This is at the mucobuccal fold of the first premolar, aiming towards the infraorbital foramina located 5 to 10 mm below the infraorbital rim. The maxillary incisors and canines are innervated by the anterior superior alveolar nerve. This nerve, along with the infraorbital nerve, innervates the corresponding labial gingiva, and so it may be necessary to administer blocks to both nerves if anaesthetizing the labial gingiva is required for dental treatment. To administer anaesthetic solution to the ASA, a solution must be washed over the nerve by injection at the mucobuccal fold at the level of the canine eminence, as demonstrated in this image. This image summarises what we have covered so far. The maxillary branch of the trigeminal nerve innervates the entirety of the maxillary teeth and corresponding gingiva. The soft palate mucosal surface is innervated by the lesser palatine nerve, and the hard palate is innervated by the greater palatine nerve, except for the gingiva of the maxillary incisors, which is dually innervated by the nasopalatine nerve and the greater palatine nerve. M3, M2, and the palatal and distal root of M1 are innervated by the posterior superior alveolar nerve. Premolar 1 and 2 and the mesial root of M1 are innervated by the middle superior alveolar nerve, and the canines and ipsilateral incisors are innervated by the anterior superior alveolar nerve. The buccal gingiva of the molar teeth are innervated by the posterior superior alveolar nerve. The buccal gingiva of the premolars is dually innervated by the infraorbital and the middle superior alveolar nerve. And finally, the labial gingiva of the canines and incisors is dually innervated by the infraorbital nerve and the anterior superior alveolar nerve. We'll now move forward and look at the mandibular branch of the trigeminal nerve. This picture shows V3 from the medial aspect. The head has been sawn in half down the midline, and we are looking at the right side of the head from the inside. The muscle with the bite taken out of it is the medial pterygoid. At last we can see the motor root of the trigeminal nerve clearly. You'll remember that it is covered up by the sensory components in the trigeminal nerve in most of the slides we have seen so far. Immediately after they emerge into the infratemporal fossa, the motor root merges with the mandibular nerve. This means that V3 is the only division of the trigeminal nerve to contain motor fibres as well as sensory fibres. Immediately after the motor root has joined, V3 sends motor branches to several muscles. The only one of these branches you need to know about is imaginatively named nerve to the medial pterygoid. Just after these branches leave, V3 divides into smaller anterior and a larger posterior trunk. However, before we get onto those, let's just mention the round structure that you can see in this picture. If you've worked this out, then I'm impressed. This is where the otic ganglion, where the preganglionic fibres of the glossopharyngeal nerve synapse. We'll cover these later. We return here to a more familiar view of the mandibular nerve that can be seen from the lateral aspect. This picture shows the two trunks of V3 very clearly. There is a small anterior trunk. This is almost entirely motor, but it has one sensory branch. And a large posterior trunk. This is almost entirely sensory, but it has one motor branch. In this picture we can see several branches that arise from this little trunk. There are two nerves going to the temporalis muscle. These are called the deep temporal nerves. The masseter has been removed in this image, so all that's left is the nerve supplying it, the nerve to masseter. This is the little stump arising from the anterior trunk. Then there's a branch that's going to the lateral pterygoid muscle. This is actually called the nerve to lateral pterygoid. In an intact head, this nerve continues to pass through the mandibular notch before entering the deep surface of this muscle. So that's three of the muscles of mastication that are supplied by the branches that come off the anterior trunk. That leaves just one more branch of the anterior trunk to consider, the long one that runs to the cheek. This is called the long buccal nerve. Whilst the other branches of the anterior trunk are purely motor, the long buccal nerve is purely sensory. It supplies the skin over the cheek and corresponding buccal mucosa of the deep surface. Do not confuse the buccal branches of the facial nerve for this long buccal nerve. The facial nerve branches are motor branches supplying the muscles of facial expression. The posterior trunk has three branches: the auriculotemporal nerve, the lingual nerve, and the inferior alveolar nerve. All the trigeminal fibres in the auriculotemporal and the lingual nerves are sensory. The inferior alveolar nerve contains both sensory and motor fibres for part of its course. The first branch of the posterior trunk is the auriculotemporal nerve. We will come across this nerve again in the future when we look at the parotid gland. Please be very clear though, the trigeminal fibres that run in the auriculotemporal nerve have nothing to do with secretion. They are purely sensory fibres. The auriculotemporal nerve is shown very clearly in this picture. It has a rather odd and very characteristic relationship with the artery just after its branch from the posterior root of V3, in that it splits to go around the vessel. The vessel itself is quite interesting because it has considerable clinical significance. It enters the cranial cavity and runs alongside a particular fragile part of the skull, called the pterion. A blow to the side of the head can rupture this artery, resulting in a so-called extradural hemorrhage. This can be fatal. So what do the trigeminal sensory fibres running along the auriculotemporal nerve supply? Well, as you can see, it leaves the infratemporal fossa and runs up the side of the head, where it provides sensory innervation to the skin on parts of the auricle of the ear, that fleshy thing generally known as the external ear, and on the side of the head known as the temporal region. This is how the nerve gets its name. For dentistry, its probably most important function is to provide sensory supply to the temporomandibular joint. The TMJ is subject to all sorts of problems, including some that could cause the patient significant pain. The pain fibres supplying the joint are the trigeminal fibres that run in the auriculotemporal nerve for the first part of its journey back to the brain. This image gives you a more comprehensive view of the journey of the auriculotemporal nerve. Here I've highlighted a couple of regions that we have looked at. Here is the temporal region and the auricle of the ear. Here is the TMJ. We can also see the superficial temporal artery and the maxillary artery, and the auriculotemporal nerve emerging just after the maxillary artery and travelling superiorly within the temporal artery. On this image, I have returned the parotid gland to its home just behind the ramus of the mandible, and here we can see the auriculotemporal nerve. It emerges just behind the parotid gland. In this picture, we can clearly see the sensory branch of the mandibular nerve running through the infratemporal fossa, just superficial to the medial pterygoid muscle, and then on towards the tongue and other nearby soft tissues. One of the key features of the lingual nerve is that it supplies the lingual gingiva of the mandibular teeth. It does not provide any supply to the teeth themselves. The lingual nerve also provides general sensory supply to the anterior 2/3 of the tongue, that carries the facial sensory fibres that service taste in the same area. It also transmits secretomotor facial nerve fibres to the submandibular and the sublingual glands. You'll remember that all of these facial fibres get to the lingual nerve when it's joined by the chorda tympani. Another important feature of the lingual nerve is that it runs through the infratemporal fossa, just a few millimetres anterior to the branch of the mandibular nerve we're going to consider next, the inferior alveolar nerve. Because the lingual nerve lies so close to the inferior alveolar nerve at this point, applying local anaesthetic in this region blocks both nerves at the same time. On this image, we can see the lingual nerve within a cadaveric donor. If you are wondering where you can find images like this, grab a digital copy of Gosling's Human Anatomy from the library, and you'll be able to see a sketched image at the side of a cadaveric image to help you identify the structures within the picture. The textbook itself is in a little too much detail for dentistry practice, so be cautious when using the book for revision. But the pictures and descriptions of the images are very good. This picture isn't entirely useful for the inferior alveolar nerve, as a whole stretch of the nerve is missing. The missing section lies inside parts of the mandible that have been removed, so we can see more deeply into the face. That said, we can see the inferior alveolar nerve as it emerges from V3 at the same time as the lingual nerve. It effectively splits to produce two nerves. The inferior alveolar nerve initially runs downwards through the infratemporal fossa, just behind or posterior to the lingual nerve. Just like the lingual nerve, it is lying immediately superficial to the medial pterygoid muscle at this point. Just before it enters the mandible, the inferior alveolar nerve gives off its one and only motor branch of the posterior trunk of V3. This is the nerve to mylohyoid. There are no prizes for working out what this supplies, as this supplies the mylohyoid muscle in the floor of the mouth. It is far less obvious that it also supplies the anterior belly of the digastric muscle. The posterior belly is supplied by the facial nerve. Before we carry on to look at the inferior alveolar nerve, let's just divert for a memento just to make sure that you know about the mylohyoid muscles, as these are significant relevance within the clinical dentistry. The first picture shows the left and right mylohyoid muscles. They arise from the mandible and run downwards and medially to fuse at the midline, though you can't see where they join as there's another muscle in the way. The two fused mylohyoid muscles form a sheet of muscle in the floor of the mouth. You can see that they, as their name suggests, also are joined to the hyoid bone. The mylohyoids have an important role in the early stages of swallowing, when they move your tongue upwards and towards the hard palate in order to push the bolus of food back towards the pharynx. The mylohyoids arise from a very prominent ridge of bone that lie on the deep surface of the mandibular body, one on each side. These are called the mylohyoid lines. They are important in the field of dentistry prosthetics, so you need to know where they are. The nerve to mylohyoid comes off the inferior alveolar nerve and runs in the groove that lies just below the mandibular foramen. This is called the mylohyoid groove. It is visible on both pictures on this side. This image also shows the inferior alveolar nerve as it enters the mandible through the mandibular foramen, just after the nerve to mylohyoid branches from it. Once inside the mandible, the inferior alveolar nerve runs anteriorly through the mandibular canal. This can also be called the IA canal. As it does so, it gives off a tiny unnamed branch which supply the mandibular molars and the second mandibular premolars. In the region of the second premolar, the inferior alveolar nerve splits into its terminal branches, the incisive nerve and the mental nerve. The incisive nerve continues in the mandible to supply the first mandibular premolar, the mandibular canine, and the mandibular incisors. Note that the central incisor can also receive innervation from the contralateral incisive nerve as well. The mental nerve leaves the mandible through the mental foramen. You'll remember we first met this way back when we were looking at the skull. The mental nerve supplies the skin and the mucosa covering the lower lip and the labial buccal gingiva of the incisors and canines and premolars. That leaves the buccal gingiva of the molars to consider. These are supplied by the long buccal nerve. This is a sensory branch of the anterior trunk of V3 that we came across earlier. It is important to remember these gingiva are not anaesthetised by an inferior alveolar nerve block. Now we have looked at the course and innervations of the mandibular branch of the trigeminal, let's have a look at some of the blocks that can be applied to these teeth. The inferior alveolar nerve block is one of the most frequently used in dental procedures. It is also called an inferior dental or ID block because the inferior alveolar nerve is often incorrectly called the inferior dental or ID nerve. It aims to anaesthetise the inferior alveolar nerve in the infratemporal fossa just before it enters the mandibular foramen. In the case of the maxilla, we saw how nerves supplying the teeth were different to those supplying the gingiva of their medial or palatine aspects of the greater and nasopalatine nerves. In the case of these nerve blocks, different procedures were required to anaesthetise these two sets of nerves. In the mandible, the nerve supplying the teeth, the inferior alveolar nerve, including its terminal part, the incisive nerve, is also distinct from the nerve supplying the gingiva on the medial or lingual surfaces of these teeth. However, just a single nerve block, the inferior alveolar nerve block, is used to anaesthetise both of these sensory supplies simultaneously. This is because the inferior alveolar nerve and the lingual nerves lie close to one another at the site of the anaesthetic solution is injected, just before the inferior alveolar nerve enters the mandible. So an inferior alveolar nerve block should anaesthetise all ipsilateral mandibular teeth, the lingual gingiva of these teeth, and the buccal and labial gingiva of the premolars, canines, and incisors, which are supplied by the mental nerve. Remember that the central incisor can receive innervation from both sides of the head, so it may remain sensitive even when an ipsilateral inferior alveolar nerve block has been applied. The buccal gingiva of the molars is supplied by the long buccal nerve, which is not affected by an inferior alveolar block. A buccal block will anaesthetise this gingiva. The procedure aims to block the buccal nerve as it crosses anteriorly to the ramus of the mandible on its journey to supply the teeth and associated structures. It should be clear by now that a buccal nerve block alone will not anaesthetise any teeth. As we mentioned before, the inferior alveolar nerve branches in the region of the premolars. One branch comes out of our mental foramen as the mental nerve, while the other continues inside the mandible as the incisive nerve. A mental nerve can be blocked as it emerges from the mental foramen. This is usually located between the two apices of the lower premolars. The mental block anaesthetises the lower lip and labial buccal gingiva of these incisors, canines, and premolars. If you want to block the anterior teeth at the same time, without resorting to an inferior alveolar nerve block, you can modify the mental block to produce the incisive nerve block. The incisive nerve block is very similar to the mental block, but it uses a greater volume of anaesthetic solution, and pressure is applied to the region of the mental foramen as the solution is injected. This forces the solution into the mandibular canal, blocking the incisive nerve. Of course, it also blocks the mental nerve, as it is bathed in anaesthetic solution as it emerges through the mental foramen. The incisive block anaesthetises the same structures as the mental block, as well as the teeth supplied by the incisive nerve. And that brings us to the end of the trigeminal nerve. You should now be able to revisit these slides in order that you can meet these learning objectives.